Good evening and welcome to Let's Just Talk. I'm your host, Hammi. Today, we'll be discussing the opioid crisis, a crisis that has been responsible for more than 90,000 deaths in 2020. To paint a picture, according to Dr. Modestino here, that's more Americans who have lost their lives to overdose than the combined deaths from car accidents, gun violence, and AIDS. And it's even greater than all U.S. military and casualties in Vietnam and Iraq combined. Here to help us understand and address this crisis, we are joined by Dr. Alicia Sasser, a professor with appointments at the School of Public Policy and Urban Affairs and the Department of Economics at Northeastern University. She also serves as the research director at the Dukakis Center for Urban and Regional Policy. She is a fellow at the Harvard Kennedy School's Women in Public Policy program and a non-resident fellow at the Brookings Institute's Metropolitan Policy program and an affiliated researcher with JPAL at MIT. And we have here Dr. Thomas Stopka. Did I pronounce that right?
Stopka.
Stopka. He is an epidemiologist and associate professor with the Tufts University School of Medicine. Since 1999, his research has focused on the intersection of substance use, infectious disease, and opiate overdose. He currently leads and contributes to clinical trials and observational studies funded by the NIH, CDC, and SEMSHA. Dr. Stopka is also co-chair of the Tufts Research Cluster, focused on equity in health, wealth, and civic engagement. He teaches courses in GIS, spatial epidemiology, and research methods. To start, we are going to give each of our guests 5 to 7 minutes to offer their perspective on this issue. And who should we start with? Dr. Stopka, you want to?
Sure, I'll be happy to start. And Hammi, thanks for having me. I really appreciate it. This is such an important topic.
Of course.
So let's just talk a little bit about the numbers and about this current opioid crisis. This past year, actually, we saw more than 100,000 opioid overdose deaths during the first year of the COVID pandemic. How do we get here? Well, we often talk about 3 waves of the opioid crisis, or 3 waves of the opioid overdose epidemic. The first wave started in the 90s and into the 2000s, focused on prescription opioids. And pharma, Purdue Pharma, for instance, who prescribed OxyContin, and the Sackler family that owned the company, promoted prescription opioids as if they weren't a risk for addiction and overdose. And so they were prescribed very readily and in high quantities in all corners of the US. And over time, that led to folks that fell into the throes of addiction in many cases. Over time, clinicians, big pharma, public health officials started to realize this huge risk and challenge. And so we started to see a leveling off of prescription rates. We started to see prescription drug monitoring programs. We started to see an understanding that we can't prescribe 90 pills for somebody who's blown out their ankle or torn their ACL. We need to limit the number of prescriptions. So we began to transition from wave 1 to wave 2.
Right.
And in wave 2, as prescription opioids started to diminish, folks who are in the throes of addiction can't immediately stop because withdrawal symptoms that are tied to cutting back on opioids can be the worst flu, the worst intestinal bug, the worst pain you could ever imagine experiencing all together. And so folks who prescriptions started to diminish then had to find other substitutions. And heroin became one of the leading drugs of choice for people who are addicted to opioids. And that's when we started to see overdoses creep up at an even steeper pace. That was around 2010 to 2013. In 2013, the third wave of the opioid crisis began, and that's when fentanyl, synthetic opioids, and namely fentanyl, started to come into the mix. And that's when we saw this very steep increase in opioid overdose deaths, because fentanyl is 50 times more potent than morphine. 50 to 100 times more potent than heroin. And so folks, even who got small trace elements of fentanyl, whether they expected it or not, could overdose very easily. And so wave 3 transitioned to what many folks think about today as wave 4. We're not only seeing fentanyl in opioids, but fentanyl is also starting to appear in stimulants like cocaine and methamphetamine. And so during and over the course of these 3 or 4 waves of the opioid crisis, we've seen opioid overdose deaths quintuple in many places. Here in Massachusetts, we went from a few hundred opioid overdose deaths a year to over 2,000 opioid deaths a year. And we started to see a leveling off of opioid overdose deaths in the past 5 years or so, until COVID came along. And now we started to see an increase again in opioid overdose deaths here in Massachusetts and also across the US. And so that's the general landscape that's gotten us, through this current opioid overdose crisis. There have been others in the past. I just want to make sure we understand how ubiquitous this is, right? This current opioid overdose crisis impacts people in urban communities, suburban communities, and rural communities. And there haven't been sufficient resources in all of those places to respond accordingly. There's starting to be a response that starts to echo or mirror what the needs are, but it's taken quite some time. But overdose has struck close to home for all of us. When we talk to friends, family members, students, it's rare that we talk to somebody who doesn't know a person who's overdosed, or a family member, or a friend, or a distant relative who's been really coping with addiction to opioids, and many who unfortunately have passed.
Thank you for that. And I personally can relate to that as well. Like, know of many people who are dealing with addiction, or some people who have passed from overdose. And Dr. Modestino, would you like to?
Yeah, I'll pick up the thread right where you left off, and start off with the point that even though it's very ubiquitous, it's everywhere around us, there's certain populations that are affected more than others, and so this is developed unevenly, both in terms of people's racial and ethnic identities as well as where they live, So there's actually higher rates of overdose, and even the initial prescribing that we saw in rural versus urban areas, which has been kind of, I think, surprising to some, because we usually think of, medical kinds of treatments and technologies starting in urban areas where there's teaching hospitals and things like that, and that's not really where opioids started. And if you go back and look at the history of what Big Pharma did, and Purdue Pharma in particular, they targeted places, where people would need these kinds of treatments and medications. So places where you see a lot of blue-collar jobs, where people are doing very physically demanding labor, where they might not be able to take time off from work to be able to go have a surgery or something like that, where they needed to get back to work rather quickly, and they needed their pain relieved, So that's where you see it spreading in coal country in Appalachia and more rural areas to start with. The other thing that was interesting was, at least in the beginnings, it was very much higher prescribing and opioid addiction and deaths among non-Hispanic whites, which is something that I think we also didn't expect. But there's also an element here in terms of whose pain is listened to and who is given these kinds of treatments, And so for quite a while, it was not the case that these were the highest rates, at least among prescription opioids, among Black and brown communities, And that has since flipped, So the script has really flipped in terms of where we're seeing the most dramatic increases in terms of opioid addiction and abuse and deaths now, where it's now more in Black and brown communities and among those populations, or rising more rapidly in those populations. The other thing that I wanted to just sort of paint the broad brush with is there's tremendous loss of life and anguish that we have all experienced in knowing somebody who may have overdosed or died. But there's also a huge economic cost to this as well, So, we're talking upwards of, $80 billion in terms of economic loss that stems from everything from the actual medical treatments that people are receiving to substance abuse treatment for addiction, to loss of productivity and wages from not being able to work, to thinking about other kinds of alternative treatments that we can come up with, to other kinds of policies as well, right? And also avoiding the criminal justice system and incarceration as well, right? So that's a whole other component that makes this a really super expensive problem compared to other social ills. And I'll just give you like a little bit of an outline of how we think about public policy coming into play in this area. We think about really how it's trying to address both the supply side of medications coming in, as well as the demand side of people seeking these kinds of drugs, right? So on the supply side, we've done things to try to limit the amount of opioids that people are prescribed, right? As Dr. Stopka was talking about. Which has, some unintended consequences potentially, but at least could be a tool for limiting future addiction, right? So if you are now a patient who goes in who has not ever had opioids before for, say like a minor injury or a minor surgery, we're not going to give you a 90-day supply of opioids now, which is a very good thing. Other things that, have been put in place have been things like the prescription drug monitoring programs, where doctors now will go and look at your prescribing history to make sure that you're not abusing opioids. And there's good and bad things about those programs as well. Some of the new kinds of things we're also trying to pursue to limit supply is also the diversion to secondary users. So it might be that I get a prescription for a particular injury or a surgery or something like that, and there's medication left over. What do I do with it? It's probably sitting in my medicine cabinet right now. That's super dangerous, right, to people in my household, to others, who might be seeking those kinds of drugs. And so there's actually, another kind of phase of this where we're seeing drugs diverted into other uses by folks who didn't even get it prescribed to. And so we have some programs now and some interventions we can talk about getting people to bring those opioids back and dispose of them safely so that we can at least take them out of people's homes where they might be abused. And then on the demand side, there are all sorts of kinds of things that we're thinking about in terms of providing more medicated assisted treatment, right, for people who are already addicted, to be able to provide those kinds of medications that Dr. Stopka was talking about, whether it's methadone or buprenorphine, Suboxone, those kinds of things. So limiting those kinds of things. And then also, treating some of the underlying conditions that co-occur with this, kind of drug-seeking behavior. So mental health, substance abuse, those kinds of services as well. So we can touch on all of these threads, but that's kind of the lay of the land right now in terms
There's
of
a lot
policy.
of layers to unpack.
Yes.
It's like just not a one issue thing. That's why the issue is so intractable, as like, how do you address it? But first I want to go back to wave one that you were referring to, Dr. Stopka. What is it about the US healthcare system that allowed pharmaceutical companies to pump like communities with drugs, and with our healthcare system with drugs, and doctors to prescribe, more drugs than are needed to be prescribed? What is it about, particularly about the US's healthcare system, that makes that possible? Because, the opioid crisis it has its own form in other countries as well.
That's right.
But we are by far doing worst. We consume 30% of the world's opiates, but we only make up about 4%, I think, of the global population. So what is it about our healthcare system that makes us unique in that sense?
Yeah, I mean, early on there was quite a bit of deception, dishonesty on the part of Purdue Pharma, Big Pharma in general. The medical community and public health community saw one article, it was really a paragraph, that noted that prescription opioids were not addictive and there was not major risks to worry about. And some folks didn't really dig deeply to determine that that was really not a clinical trial. That was not a bona fide observational study even. It was an opinion written by somebody based on no data. And so some of the other high levels of prescribing, kind of went under the radar initially in terms of how easily accessible opioids were in terms of being disseminated to places even as far reaching in rural as Appalachia. But, you know, it took on several different components, right? We've done research on what we call potentially inappropriate opioid prescribing. And so I want to define that for people. What does that mean?
Right.
So potentially inappropriate opioid prescribing can include several different types. One could be prescribing at very high levels. We usually measure opioid prescriptions in what we call morphine milligram equivalents.
Right.
And when that gets to be above 90 morphine milligram equivalents, that's a very high dose. And oftentimes people were being prescribed much higher doses than that. So that raises a red flag. Another is when people would co-prescribe opioids with benzodiazepines, right? These are anti-anxiety meds. But when those two are offered together, if somebody overdoses, it's particularly hard to revive them from an opioid overdose.
Right.
Another component of overprescription or potentially inappropriate opioid prescribing related to folks receiving prescriptions from multiple prescribers, multiple providers, another red flag. Or going to multiple pharmacies to fill that prescription.
Right.
Or people who get high doses of opioids but don't have a cancer diagnosis. Oftentimes, folks who are living with cancer are living with extreme pain. You might expect to see higher doses, but oftentimes we're seeing that people who without that type of red flag were being prescribed opioids. So the prescription drug monitoring program aimed to try to detect these potential issues. And as was mentioned, there are some goods and some bads about that. But, you know, those were some of the root causes of the current crisis. Really some deception, large numbers of prescription opioids being disseminated and distributed to all nooks and crannies of the U.S. And there being a big time lag in the clinical field, public health officials, and Big Pharma acknowledging that this was an issue, this was a concern.
Right.
I think the other thing is even just the economics of healthcare in the United States compared to other places, right? So it's not like people in the U.S. are more likely to be addicted, right? Or more likely to crave those kinds of treatments. But the way the U.S. healthcare is set up with, for example, direct-to-consumer advertising, right? Who hasn't watched those commercials on TV that, you know, you don't even know like what exactly it is, right, that they're advertising, but you're like, wow, that person looks really happy, and how do I get that? And then they list all those sort of symptoms or side effects or whatever really at the end. Right, so there's that, and there's big money in pharmaceuticals here in the United States, right? Because of the way we reimburse for healthcare, right? Because we don't have a public healthcare system, right? We don't have a uniform payer system. We have private healthcare in the United States. That means the more stuff you do, the more you get reimbursed for that, right? As a physician, as a hospital, and you know, Purdue Pharma kind of perfected the practice of paying physicians, right, to be giving talks about their drugs, to be helping them even spread the word about using this in terms of treatment. They, you know, paid thousands of dollars to physicians right here in Massachusetts to be able to do that kind of advertising and marketing for them under the radar, kind of peer-to-peer, because there's big money in pharmaceuticals here in terms of how we reimburse it. And so we get a little upset, right, that other countries will not pay the same price for pharmaceuticals, the same pharmaceutical here in the United States. They won't pay as much abroad, and companies cut their prices for that, but they don't here in the U.S. And so that's why we lead in terms of a lot of beneficial pharmaceutical treatments, but also have led in terms of opioids, which were not beneficial, you know, in terms of how they affected people and how they spread so rapidly. And that sort of model in the United States, you know, that profit model really drives, again, then the pharmaceutical industry to be lobbying, right, against regulations, right? So there were lots of kind of red flags that people saw, but did not take action on, you know, collectively in terms of regulating this industry, and even the crazy easy labeling that they got initially on their pharmaceuticals to say that, I forget what the exact wording was, but they didn't have to put a warning on it to say, it was the first opioid that they could prescribe and they could advertise that didn't have the warning label that said this was addictive, right? And it was because of that marketing and because they had lobbied the FDA to keep that off of their label. So I think, you know, the way that medicine is set up in the United States really just lent itself to, you know, rapid spread.
And so 2 follow-up questions about that. The first one is, people have conversations around, should we regulate the pharmaceutical industry to the point where, the same way that other countries do it? And then opponents to that always argue, well, if you do that, it limits innovation. You know, all the best medicine comes out of the US. If you're sick and you're dying, the place you want to be at is in the US. And that comes at the high cost that we pay and the price that we pay for healthcare. Do you agree with that? Does regulating these industries and these companies that are making billions of dollars, will that limit innovation in the way that people and policymakers are saying that it would? And then number 2, in the area of accountability, how do we hold these institutions, these companies and industries accountable for the ravaging epidemic that they've created?
So I'll take the first one, and then I'll give you the accountability one, because I think you have good points to make on that one. But so economists don't like to think about this in terms of black and white, like regulate, don't regulate.
Exactly.
Like none of that ever makes sense, right?
Right.
And so there's trade-offs. There's always a trade-off between innovation and regulation in any industry, right? In that we can think of in the United States. And so I think the question is, like, where are we on that spectrum in terms of regulating pharma in particular, even compared to medical devices or other, you know, parts of the medical industry. And I think, you know, from what we've witnessed with the opioid crisis, we're clearly on the wrong side of regulating that industry. And so clearly more regulation and oversight is needed. And also, you know, making sure that we have more independent oversight. And, you know, I think that was particularly disheartening that the FDA did not do the job that they should have done. And it was really kind of whistleblowing that you know, sort of brought a lot of this evidence to light. And I think also the peer review system really broke down here, right? And Dr. Stopka alluded to this as well, right? We're supposed to have a peer review of things that appear in medical journals to make sure that there's agreement, right, among the medical community that yes, this is a beneficial treatment, or yes, it's not addictive, it doesn't have this. And there somehow this got by, right, all of the peer review that was out there. So there's multiple ways I think that we can regulate the industry in terms of maybe the amount of lobbying they're allowed to do, better oversight in terms of what is acceptable for peer review, and then really strengthening the FDA to make sure that they're not hiring people into the FDA who previously had worked in pharma, who might be very sympathetic, to drugs being brought online.
Thank you for that.
Yeah, and to the second question about accountability, well, what's currently happening with many of the pharmaceutical companies that are guilty of overprescribing, over-distributing prescription opioids is there have been a lot of lawsuits, right? And some of those lawsuits have been settled. And I was just on a call earlier today with some officials here in Massachusetts and researchers and public health officials, and the Johnson & Johnson and McKesson settlements are about to pay out during the upcoming year and the upcoming 20 years here in Massachusetts. So for some of these large companies, the settlements probably equate to a very small proportion of their overall profits in a given year, but Massachusetts is going to receive upwards of $500 million dollars to respond or as a part of the settlement over the next 20 years. And so that'll equate to somewhere between $20 and $50 million per year between this year and the next 20 years. So that can help to fund opioid treatment programs, medications for opioid use disorder, harm reduction initiatives, increased access to naloxone, the antidote, right, to reverse opioid overdoses. So we're still waiting on the settlement with Purdue Pharma and with the Sackler family, but it seems like an agreement, a settlement is getting closer, and that will be another settlement that will produce good amounts of money to help to be distributed to all of the impacted states and communities. Will it replace the hundreds of thousands of lives lost? No. But can it begin to hopefully start to change the direction of the opioid overdose curve so that it levels off and starts to go down in the right direction? That's the hope.
Okay. And then 2 follow-up questions to that, because you mentioned naloxone.
Naloxone, yes.
Naloxone, and then you also let's start with naloxone first. Should preventative care like that be made widely available to the public for use?
Yes.
And then what are the consequences of that if those sort of things are made widely available to the public? And then number 2, how do we coincide with the fact that these are basically what you are referring to is you've caused the fire, now put it out. So these same companies that are responsible for this crisis are now also responsible for a lot of the preventative cares that's coming out. And so how do we coincide with the idea that they're in the business of making profit, but also we need to rely on them for some sort of like solution to this problem?
Yeah, I'll talk about the naloxone first. So naloxone is a highly effective medicine that can be sprayed into a person's nostril to help to reverse the effects of what would otherwise be a fatal overdose.
Right.
It's been used, it's been disseminated across Massachusetts, it's been disseminated across many communities throughout the U.S. It's not enough, we need to get it out to more communities. In Massachusetts, we have a program called Opioid Education and Naloxone Distribution Program. So there are more than 30 programs throughout the state that are disseminating large numbers of naloxone to family members of people who might be in the throes of addiction, to people who themselves are in the throes of addiction. They might be able to rescue their friend, their peer, their family member, and to harm reduction and public health programs. And they've saved thousands of lives in here in Massachusetts alone, tens of thousands of lives across the U.S. They're a tremendous tool and one that we need to make more available to save tens of thousands and perhaps hundreds of thousands of additional lives.
Okay, thank you for that. And then do you want to take on the second question?
Yeah, can you remind me what it is?
Oh, it was around having to rely on the people who caused the fire to put it out.
Yeah, I mean, that's the case in a lot of different sectors that we might think about where the only remedy, right, is to go back to the entity, right, that caused the harm. So I think one thing that we want to remember is that kind of going back to your earlier point, right? Pharmaceutical companies create life-saving medications every day, right? So it's not like the entire sector is evil, right, or doing bad things, but there can be bad actors and there can be bad consequences, and a lot of it comes down to the incentives, right, of profit over making societal goods. But we can't, at the end of the day, forget that they are profit-making entities, right? And so we would not have a lot of the life-saving drugs that we have right now if they were not allowed to make a profit off of it. So, I mean, in some ways it might feel unpalatable to go back to the industry for the solution. But I think also, patients, employees of these institutions are demanding better choices, right? And so we've seen this in many, many areas, right, of our economy where people are demanding better choices of their employers and their institutions, whether it's educational institutions, right, or other organizations that they work for, that they want responsible, just, right, kind of stewardship. And so you hope that these things are going to bubble up as well and guide these, companies to make better choices. And then we have the oversight, right, to make sure that they do. And part of the other benefit of these lawsuits, you might think like, well, these dollars are never going to replace the lives lost, which is totally true. But at the same time, they should be deterrents, right, to companies to behaving like this in the future, right? Because you will pay a very high price. And if you think about how far the Sackler suit can go into the personal pockets, right, of the individuals who own these companies, then that should certainly make you think twice about pursuing anything that's profit over making sure you do no harm.
Yeah, thank you for that. And then to start wrapping up the conversation a little bit, could we start talking about some of the work you and your colleagues are doing to address this issue? What are some of the policies that are being put forth across states to address and curb this issue? And are there any unintended consequences we should be thinking about when we're making policies or having conversations or doing research and so on relating to the opioid crisis?
Sure, I'd be happy to start in talking about some of the intervention work that we're doing. So there's 3 NIH CDC funded studies that I lead or contribute to. One is focused on the rural opioid epidemic. And so we're focusing on Western Massachusetts, Vermont, and New Hampshire. Really 11 counties along the I-91 corridor, the Connecticut River Valley, from Western Massachusetts up into Vermont and New Hampshire. And so currently, we're about to go, we were in the field and collecting data for 2 or 3 years to learn about the extent of risk for overdose, for hepatitis C, which is strongly correlated with substance use, opioid use, especially injection drug use, as well as HIV pockets that are showing up related to injection drug use. We're going to be initiating a mobile telemedicine-based hepatitis C treatment program for people who inject drugs. And along with that, we'll provide harm reduction, health education messages, and referrals to other services. That's one study. Another is the Healing Community Study. HEAL stands for Helping to End Addiction Long Term. And it's one of the NIH's large funding initiatives. And Massachusetts, Ohio, New York, and Kentucky were funded to the tune of $90 million each, with the aim of decreasing opioid overdose deaths by 40% in 67 intervention communities. So Boston University, Boston Medical Center is the lead agency on this study. I'm one of the co-investigators, and we oversee the geomapping and geospatial analyses of opioid overdose and the response. So that study is ongoing with hopes of decreasing overdose risk by 40% in the next couple of years. The third is a program in which we're evaluating an initiative that went into effect, legislation that Governor Baker signed into law that went into effect in September of 2019, which requires that jails in Massachusetts, houses of corrections, provide access to medications for opioid use disorder. So methadone, buprenorphine, Vivitrol. These medications, especially some of our previous research focused on methadone and buprenorphine, have showed 50 to 60% decreased risk for overdose when people are on these medications. A large proportion of people who are incarcerated go in with opioid use disorder. And a large proportion go in when they were on medications for opioid use disorder. And instead of discontinuing that medication, which was the norm in years past, they're able to continue on those medications during their incarceration so that when they're released, they can continue with the medications ideally as well. Because people who are released from jails and prisons are at the highest risk for opioid overdose. In Massachusetts, the Massachusetts Department of Public Health, in some of their studies, have shown that people who are released from jail are at 120 times increased risk of fatal overdose during the days and weeks post-release. So this initiative, we're trying to see how well the program is implemented and what are the overall impacts over time in terms of decreasing overdose risk, particularly when people transition back into the community, right? Corrections facilities are meant to be just that, provide people with another chance to help to get them on a new path. But they've got to continue to live and avoid overdose and overdose death so that they can continue on a path, a new path that was started through a corrections facility.
Thank you.
And that, it's interesting, our work really like kind of dovetails very nicely. So I'll pick up on a couple of those threads. So one of them is thinking more about these medication-assisted treatments, even beyond the context of folks who have been incarcerated, but really understanding who benefits from them and how do we keep people from discontinuing their medication. Because I think one of the most disheartening facts that we've found in our research that we've been doing with the Massachusetts Department of Public Health is that 25 to 30% of people discontinue buprenorphine or Suboxone within the first month of taking it. So voluntarily just go off of it. 50% discontinue within 6 months. And for the most part, clinicians are saying people need to be on this medication at least for a year, if not 3 years, 5 years. And for young people in particular who have been addicted, you know, at younger ages, like as teenagers or young adults, they're saying it might be a lifetime treatment because it has really altered the brain chemistry to the point where it would be very hard to fight those addiction cravings if you are not receiving this very low dose opioid that's like a maintenance treatment every single day. And then understanding better who responds to which treatment. So buprenorphine is something that you can be prescribed by a physician, that you can get a 7-day prescription, you can take it each day at home, you go back in and you check in with the doctor. You know, methadone is where you show up at the clinic every day and you get your treatment. Some folks can do fine managing it themselves. Other folks need that touch point every single day, that accountability, the other services that come with that. And so we're helping clinicians develop models to be able to predict to some extent who would benefit better from each of these treatments. Another thing that we're working on with the Department of Public Health here in Massachusetts is learning more about why is opioid prescribing still higher in rural versus urban areas. And what we have found is some of it is economic, like I was talking about. So in rural areas, you do find people more in blue-collar jobs who are seeking these kinds of treatments, or they don't have access to alternative pain treatment. So you don't live close enough to be doing physical therapy every day for a back injury. You don't live in a place that has a you know, high quality surgical option, or you don't have medical coverage for acupuncture or things like that. And so, you know, you end up taking an opioid every day, right? That becomes your default. The other thing is that there's fewer pain specialists in rural areas. So in Boston, right, if you were you know, seeking an opioid, or you thought an opioid might be an appropriate treatment for you, you'd probably see a pain specialist who would determine if that was the case. Out in rural areas, it's more likely you're seeing a primary care physician, or maybe even an ER doctor who is prescribing and maybe not necessarily thinking about the downstream effects as much in terms of addiction. And one of the things that's changing here nationally is that it had been the case to be able to prescribe an opioid, you didn't need any kind of special waiver, but to prescribe the treatment for opioids, so methadone or things like that, you had to have special training to be able to do that. So now we've changed that rule, I think as of April 2021, where physician's assistants and other doctors are much more free to be able to prescribe the treatment to opioid addiction, which makes a lot more sense. And then the third thing I'll just talk about is we actually have an intervention that is a field study that we're running here in Massachusetts to be able to collect those opioids out of people's homes that I was mentioning earlier on with an opioid bring-back program. So initially it started as a buyback program where we incentivize folks to bring back their unused opioids to their community health center where it was prescribed for them. And now we've actually, because we had to pivot during COVID, we couldn't be asking people to come back to community health centers during COVID, we pivoted to a mail-back program, which seems to be much more effective. So when you get prescribed an opioid, now we're running a randomized control study to show that if I give you a mail-back envelope to be able to put your unused medication in, are you more likely to be able to dispose of the 3, 5, 10 pills that you might still have at home, so that we can at least get it out of your household and know that it's not going to be diverted either to someone in your home or to the black market or into the community.
Dr. Modestino, Dr. Stopka, it was great having you on Let's Just Talk. We'll keep these conversations going, and I look forward to working with you all in the future.